Assalamu alaikum. Our lecture today is post-term pregnancy, an evidence-based approach. Post-term pregnancy is defined as pregnancy that has lasted until 42 weeks or more, or 294 days, or 14 days or more after the due date, let's say estimated date of confinement or delivery. Prolonged pregnancy can be defined as a pregnancy that has been lasted until 41 weeks or more, or 287 days or or more 7 days or more than the expected date of delivery. The term post date can signify a pregnancy that lasted until 40 weeks or more, or 280 days or more, but it is often defined differently in the literature and should be probably avoided. Epidemiology of post-term pregnancy. The incidence of post-term pregnancy is about 7% worldwide, differing from a country to another. The etiology of post-term pregnancy, the most frequent cause of post-term pregnancy is an error of dating. The risk factors include poor dating or wrong dating, prior post-term pregnancy, nulliparity, long, more than 28 days cycles without early ultrasound, placental sulfatase deficiency, anencephaly, and it is common with male fetuses than female fetuses. The complications of post-term pregnancy are either fetal or maternal. The fetal or perinatal complications include meconium aspiration, intrauterine infection, oligohydramnios, macrosomia, non-reassuring fetal heart rate tracing or testing, low umbilical artery pH, low 5-minute Apgar score, perinatal mortality is twice as high as at term when the delivery is 42 weeks or more, and it is 6 times more than term when the gestational age is 43 weeks or more. Dysmaturity syndrome is another perinatal complication of post-term pregnancy. It is present in about 20% of neonates born post-term and has some of the characteristics senile facies, thin parchment-like fetal neonatal skin, lanugo hair spurs, peeling of the skin, meconium staining of the skin, wasting, especially the arms and thighs and buttocks, with wrinkling of the skin. It has also some criteria, just as hypoglycemia, seizures from uteroplacental insufficiency, and unclear long-term outcome, but increased risk of infant death. Regarding the maternal complications of postterm include labor dystocia, perineal injuries, third and fourth degree perineal tears, and increase the incidence of cesarean deliveries with their complications. Pregnancy considerations. Every woman should be counseled early in pregnancy that up to 50% of gestations, especially in nulliparous women, last until past the due date. This is physiologic and natural for humans. The incidence of fetal death is significantly higher than that of neonatal death at more than 40 weeks and 3 days. In large series, delivery at 38 weeks in association with is associated with lowest risk of perinatal deaths, but the risk is of perinatal deaths is about 1 to 2 per thousand or less up to 41 weeks and 6 days. It is important to identify the risk factors such as maternal hypertension, diabetes, etc., and fetal growth restriction disease that necessitates special management. About the management of postterm, we start with the preconception counseling. Women with prior postterm pregnancy are at increased risk of for recurrence of the postterm pregnancy. Prevention strategies should be discussed with the patient to prevent the possible causes. Workup, early ultrasound less than 20 weeks of gestation can prevent postterm pregnancy and therefore the need for induction of labor. Regarding prevention or preventive methods, routine early ultrasound to reduce postterm pregnancies, stripping of membranes starting at 38 weeks. It is done weekly until reaching 40 to 41 weeks. Breast and nipple stimulation to reduce post-term pregnancies. Breast and nipple stimulation daily performed by the patient herself at 39 weeks has not been sufficiently studied to ascertain safety, but it does appear to reduce the incidence of post-term pregnancy by about 50%. Antepartum testing. Since the fetal death rates increase incrementally after the expected date of confinement, it seems reasonable to test fetuses to assure well-being, especially at or beyond 41 weeks of gestation. The most used options include non-stress test, biophysical profile, and modified biophysical profile. Modified biophysical profile includes non-stress test and ultrasound measurement of maximum pool depth of the amniotic fluid volume. Biophysical profile has five components, four ultrasound assessments and a non-stress test. The non-stress test evaluates fetal heart rate and response of the fetal movement. The discrete biophysical variable are included in the next table. They include non-stress tests as we mentioned, the normal non-stress test should include at least 2 accelerations in 20 minutes. The fetal breathing movement, at least one episode of more than 20-second duration in 30 minutes should be obtained to comment as normal. Fetal activity, gross body movement, at least two movements of the torso or limbs should be obtained to consider it normal. Fetal muscle tone, at least one episode of active bending and straightening of the limb or trunk should be obtained to consider it normal. Qualitative amniotic fluid volume or amniotic fluid index of feline, at least one vertical pocket more than 2 centimeter or more than 2 centimeter in the vertical axis to be considered as normal. Doppler ultrasound of any vessel, including the umbilical artery, is not effective in the management of post-term pregnancy. At 41 weeks or more, twice weekly testing with modified biophysical profile is recommended, but it is not based on trials. About the intervention in the management, if we have a favorable cervix according to Bishop score, let's say scoring of 9 or more, and the gestational age is 41 weeks, there is insufficient evidence to assess any intervention in the woman at 41 weeks or more with a favorable cervix, as no trials have focused on or included these pregnancies in insufficient numbers, as the complication of induction in these women, especially if multiparous women, are minimal to absent. It seems reasonable to offer at least, if not recommended, induction of labor. This is the Bishop score, including the cervical position, consistency of the cervix, effacement of the cervix, dilation of the cervix in centimeter, and fetal station. Scoring may be 0, 1, 2, or 3 regarding each of the assessment points. Score of 5 or less is unfavorable for induction, is unfavorable for induction, and the spontaneous delivery is remote. Scoring of 9 or more and the modified Bishop score, which included the cervical length. If the cervical score is 9 or more and cervical length is less than 1.5 centimeter, the patient is most probably will deliver spontaneously. Unfavorable cervix, routine induction of labor at 41 weeks. This protocol will reduce the perinatal mortality by about 80%. Unfavorable cervix with routine induction of labor at 41 weeks or more decrease the incidence of cesarean delivery in women who are nulliparous at 41 weeks or more induced by prostaglandins. Unfavorable cervix with routine induction of labor at 41 weeks or more in women with a prior cesarean delivery is associated with a higher incidence of uterine rupture, especially in women with an unfavorable cervix and no prior vaginal delivery. It should be avoided. We come to algorithm for concluding the management. If at gestational age below 20 weeks, the patient should have ultrasound to establish accurate dates. More than 36 weeks, consider weekly stripping of 38 weeks, consider weekly stripping of membranes if risk factor present managed accordingly. At 39 weeks or more, cervical examination, consider induction if Bishop score is 9 or more with transvaginal cervical length is less than 15 millimeters. At 40 weeks to 40 weeks 6 days, counseling regarding the induction at 41 to 41 6 days. Fetal kick counting every day. Fetal, daily fetal movement count should be recommended here. If the gestational age is 41 6 days, 41 to 41 6 days, counseling about induction and expectant management, non-stress test, and amniotic fluid volume estimation twice per week, and all women should be delivered by the 42 weeks. Here we finished the important about the post-term pregnancy, and I will let you to the self-assessment slides. Thank you very much.